yeah, I'm very humbled to be able to present Future Perspective with this very esteemed faculty, but I just want to highlight that we have seen a lot of advances in the first-line setting, and I want to really highlight that, to me, academic trials are the ones that really drive progress in this disease, because from a pharmaceutical company's perspective, this disease doesn't really hold much promise, so funding is usually quite scarce. And coming from the German Hodgkin Study Group, I'm highlighting just 2 of our early phase 2 trials, which basically set the stage for later phase 3 studies. One is the NIVAHL study, shown on the left, where you can see that it doesn't really make a difference if you add anti-PD-1 to first-line AVD treatment concomitant, so Nivo-AVD, or sequentially, Nivo followed by Nivo-AVD. And the outcomes of these patients, which is early-stage unfavorable disease, are truly excellent with 3-year follow-up and 99% PFS rate. On the right-hand side, you can see that we also did an early randomization in the phase 2 study to actually investigate 2 different brentuximab-containing escalated BRCA variants before we chose BRCA to move into phase 3 for the HD21 trial. And I think it's really important to keep in mind that these early phase 2 or phase 1-2 studies allow us to come up with the best way to use those targeted agents in Hodgkin's lymphoma, but any other hematologic cancer, to enable picking the best candidate for further exploration in a pivotal phase 3 study. We have seen these curves, and this is SWOG data recently published in the New England Journal, and also HD21 data published in The Lancet. And you can see that both these trials were able to show superiority of the experimental arm over the respective standard arm. And I think wherever you stand on Hodgkin lymphoma therapy, this is a great success for our patients. And I'm very, very happy that we are actually in a time when we can improve outcomes while decreasing some of the devastating toxicities. I now want to move on to ongoing trials in the first-line setting. First, we have seen the NIVAHL data, where we had excellent outcomes after 4 cycles cumulatively of Nivo-AVD followed by radiotherapy. And we now want to use another anti-PD-1 antibody and basically PET stratify those patients, not based on the VIL score, because we, as Jill rightly said, it has limitations in this context, but the overall quantitative MTV measurement, and subject those patients who are early MTV negative to only an anti-PD-1 treatment, and only expose those patients who are MTV positive to tislelizumab and AVD, and what's important, only irradiate those patients who have PET-positive disease at the end of treatment. It's a phase 2 trial which is occurring very fast, and we'll see a readout hopefully next year. Similarly, our US colleagues within a pharma-sponsored trial are looking at a sequential approach of pembrolizumab followed by AVD, and then doing a PET stratification to either expose patients to additional AVD, or in the case of PET positive to the disease, to escalated BRCA. And then there is a pembrolizumab consolidation with the overall idea of improving outcomes by having a feasible regimen and by sparing most of these patients of radiotherapy. We have seen some early interim data at ASH and also ASCO, and I think it will be interesting to see what actually comes out of it. If you look at the time span that basically goes around this treatment, you can appreciate that this is a very, very long treatment, and this is something that I would be quite hesitant to actually apply in a curative context for a patient. I think one of the large unmet needs due to demographic changes and the increasing overall incidence of these patients are patients above the age of 60. We have seen tremendous success with Nivo-AVD, which again is only advanced stage disease. So we have roughly 30 to 50% who are not advanced stage disease and for whom we don't have any novel data. And I'm hence very happy that there's this UK investigator-sponsored study, which is called RATiFY, looking at an anti-PD-1 lead-in and then a PET-stratified approach to reduce chemotherapy exposure in those patients who achieve an early complete metabolic response. As you can see from the top part of this relatively busy slide, the chemotherapy exposure will basically be reduced by roughly 30% in those patients who have an early complete remission, while the other patients receive a combination of anti-PD-1 AVD, as was successfully done in the SWOG study. The next slide is extremely busy. It's from our US colleagues, and what they will try to do in this study, which is termed CHL-001, is to have a combination of pembrolizumab and brentuximab vedotin in older patients, with the overall idea to have this combined targeted lead-in therapy afterwards assess fitness of the patient, with the idea to have more patients who are fit enough to receive curative intent treatment once the Hodgkin lymphoma has been debulked, basically, and then expose those patients who are fit with the combination of anti-PD-1 and AVD, those who are unfit with the combination of anti-PD-1 and a mini AVD, which is basically reduced chemotherapeutic exposure, similar to a mini CHOP that we frequently do in the non-Hodgkin lymphoma context, and preserve try to basically treat those patients who remain frail with the targeted combination treatment and also consolidate with the targeted approach. I think it's very ambitious to actually do the fitness assessment in real time and act on it. I really hope that this is going well and we will actually be able to generate some nice data in this challenging population. Similar to other diseases, we usually start to learn about new modes of action in the relapse setting because we have these heavily pretreated patients who have failed all other options. In Hodgkin lymphoma, we have seen, for example, CD30-directed CAR T-cell treatment, which Anne already mentioned. However, I think we currently have one ongoing phase 3 study, which is the KEYFORM-008, that is looking at a combined checkpoint blockade against anti-LAG3 with favezelimab and anti-PD-1 pembrolizumab in a head-to-head comparison to standard of care chemotherapy. We are interested to see what comes out there. I'm an investigator on the study, and so far we have seen, let's say, mixed responses. There are patients who actually benefit from this double immune checkpoint blockade. However, we've also seen striking responses to gemcitabine in patients who were refractory prior to going on the trial. And we will see if this ultimately produces data that is good enough to end up for another drug being approved in the relapse setting. I just want to highlight one novel concept because so far our targets have been always revolving around checkpoint inhibition or CD30, and we have not really had success with any small molecules. And more recently, we have learned that Hodgkin lymphoma seems to be MTAP deficient quite frequently. And why is this relevant? We now have a variety of second-generation PRMT5 inhibitors, which are intended to basically kill MTAP-deficient cancer cells. And these second-generation PRMT5 inhibitors are basically so-called MTA cooperative. And what this means is that basically you have a cancer cell that's MTAP deficient, and in these cells, MTA accumulates in contrast to healthy cells. And only if there's MTA present, this novel drug will inhibit PRMT5, leading to a tumor cell death because this methyltransferase is basically essential for healthy functioning. And thereby, you can induce cell death in a cancer cell while sparing the healthy cells of the body. And this will hopefully enable us to use those therapeutics which previously have failed clinical development due to toxicities. On the right-hand side, I'm showing you why I'm personally excited about this. You can see in all of these Hodgkin lymphoma cell lines, except for L428, that they really lack MTAP on the protein level. And interestingly, this is not due to a genetic lesion as we have in solid cancers, but rather to a methylation state. So it's an epigenetic mechanism. And you can see that these MTAP methylated cells are actually very, very sensitive to PRMT5 inhibitor in vitro and also in a cell line derived xenograft model. When looking at Hodgkin lymphoma biopsies, you can appreciate that roughly 80 to 90% of these cases are MTAP deficient in their biopsies. So these tumor cells don't express any of the MTAP in the vast majority or have a weak expression. And this led to an ongoing phase 1 study, which is called PRIMAVERA, and that's currently in the dose escalation part in heavily pretreated relapsed Hodgkin lymphoma patients. And I personally would be very happy to see it succeed because we would actually basically unlock a new mechanistic approach to Hodgkin lymphoma, which we have not seen in the past. And we would also have a novel oral therapeutic that we could easily combine with other treatments in this disease. Lastly, I want to briefly touch on emerging biomarkers for treatment stratification. As you might know, I and our group, we are trying to pursue a more individualized approach to a given patient. And for this, you need good biomarkers. And what you can do is to have a pre-treatment risk stratification, and we already do this by assigning patients to early stage favorable, unfavorable, or advanced stage disease. And we start to incorporate something like metabolic tumor volume or ctDNA load or TARC to basically baseline stratify those patients. In the future, we might see that we would be able to also use radiomic features or biologic characteristics and subtypes for this. And then we have the on-treatment factors, such as interim PET, which is currently done by DeVille score, so a visual assessment. But in the future, at least to me, should be done quantitatively based on metabolic tumor volume, and it should ideally also account for minimum residual disease markers such as ctDNA or TARC. Why is this now a timely topic? We have seen this very nice paper from Stefan Ahlig from Esch Alizade's group, who did biologic subtyping of Hodgkin lymphoma based on circulating tumor DNA. And you can appreciate that these two clusters are very different in their genetic makeup, and also the tumor mutational burden is different between the so-called H1 and H2 cluster. And if we look at the clinical associations of this, we can again appreciate that the H2 cluster seems to be predominantly observed in the older patients, while the H1 cluster seems to be something that we mostly find in younger patients. We have associations with EBV status, some association with sex, and importantly, a significantly worse progression-free survival in those patients who have this H2 cluster at baseline. That's from the supplement of the paper, and it basically summarizes the author's interpretation of these clusters. So they basically postulate that these are two distinct trajectories of Hodgkin lymphoma development, depending on the EBV and TP53 status and the GC reaction of these cells. And to me, it seems very likely that we might actually be able to use this if we baseline stratify a patient and try to act on it by basically exposing them to the treatment that the given subtype might be most vulnerable to. Similarly, our own group has published a classifier based on ctDNA just a few weeks ago in the JCO, where we came up with 3 subtypes. Some of them have overlapping features with what we have seen before, such as the inflammatory immune escape subtype, a virally driven and an oncogenic driven subtype. And we could importantly show that these are actually associated with differential outcomes if just treated with BRCA. And I think this is something that is really crucial, because currently, if I see a patient with advanced stage disease, I would recommend them to undergo PET-guided BRCA treatment. But in the future, if I would be able to know that they are indeed from this inflammatory subtype, I might be more hesitant to do so, because this might not be the right combination for this given patient, and we might want to explore something like checkpoint inhibition in such a patient. Lastly, and this is my last slide, I promise, we can also see that measuring on-treatment response in those patients, either by ctDNA, allows us to stratify and identify those patients who have a high risk of failure, even with an effective treatment such as BRCA. And we can use something that is even easier and cheaper, such as TARC, which is a soluble marker you can find in the serum that's excreted by the Hodgkin-Reed Sturmark cells, which is elevated in most of our patients at baseline, and then shows a striking log-fold reduction below the positivity threshold in patients receiving nivo-AVD or nivolumab monotherapy in the first-line setting. And since Jill already rightfully mentioned, you cannot really trust PET in this context. I think adding TARC to the mix and being able to use, for example, TARC and MTV could really help us to guide how we basically fine-tune the very nice nivo-AVD data in the future. And what I wanted to pose at the end of this this talk is the following question. So where do we go from here, right? We have seen substantial success, and I'm very happy about this. But are we actually addressing unmet needs with the evolving treatment paradigms? And which pieces are we still missing? And I'm hoping for some of the discussion in the faculty, but also from your end, to actually move this forward. And thank you very much for your attention.